very much, Sue. And thank you also to our three previous speakers, absolutely giants in long-term conditions. And I really don't hold that role. And really all I want to talk to you as a GP in my other roles is share my passion for health coaching with you, describe a little bit about what we've been doing in Midlands and East and share some reflections. Why am I passionate about health coaching? 3 reasons. I trained in public health as well as a GP. So with my public health hat on, when I was lead commissioner in long-term conditions for a PCT, I knew this data, as Alf very clearly sets out, which is there is a tsunami of need. This is mainly around multiple morbidity in elderly patients, but also our more deprived communities are really suffering. I also know with my public health hat on that this is costing the NHS and social services a vast proportion of our resources. So with my public health hat on, I'm aware of all the data around this huge problem. But with my GP hat on yesterday when I was on duty and receiving 60 calls a day, and as my GP colleagues here know, when we see 40 patients appointments a day, 60 phone calls a day, we are just completely overwhelmed. And the average length of consultation in general practice has increased from 7.4 minutes to 11.7 minutes, and yet we still only book for 10 minutes. And that is on the most part due to elderly patients with chronic conditions. Also, the consultation rates has increased by 40%. So not only are we spending more time with our patients, but we're seeing them more often. And we know that patients with long-term conditions consult a lot more frequently. And in an audit in our practice, when we looked at HbA1cs in patients with diabetes, even the ones who consulted more frequently, up to 16 or 17 times per year, we still weren't bringing those HbA1cs down. So I know from my public health data this is a huge problem. I feel it in my surgery, and also I know it as an individual, because I have to admit, hands up, that I feel slightly inadequate as a doctor these days. I mean, there's no way I can know absolutely everything. I have so many guidelines, bits of information. I feel just completely overwhelmed. And actually, I think propagating this myth that I do know everything is the wrong way to go about it. It won't solve these problems. And I think Angela Coulter describes it very well, building on what Margaret was saying, which is about, as a doctor, I cannot be in the driving seat. I don't have the resources to do so. And also, it's not good for patients. I think Angela describes it very well. Doing things to people instead of with them can be profoundly disempowering. Encourage patients to believe that professionals have all the answers and that they themselves lack relevant knowledge and skills and hence have no legitimate role to play in decisions about their healthcare. Paternalism breeds dependency, encourages passivity, and undermines people's capacity to look after themselves. It may appear benign, comfortable and reassuring, but it is hazardous to health. I like being treated like an adult, and I'm sure my patients do. So with this overwhelming need and very little time and sense of inadequacy, there is one thing that I can do really well, and I can talk to my patients in a way that I think is caring and empathetic and really work hard so that when they come and see me in my surgery, they go out feeling that they've been listened to, and I have taken them seriously, and we do have the start of a plan. And so when I went on my coaching training, this was executive coaching training, it was a complete revelation to me that I could be given the skills that would help somebody else solve their own problems than me having to do it for them. What a relief. I don't have to be the expert all the time. I don't have to know everything. I can have the skills to help other people solve their own problems. So I just thought this was just fantastic. And when I was doing my coaching training, I met Andrew, and we were having a glass of wine, and I was going, God, this would be fantastic for patients. What a relief if I could do this with my patients to get them solving their own problems too. And as a result, we put in for a project and got £100,000 through a regional innovation fund. So while coaching is the art of facilitating the development, learning and performance of another, we like the definition that whereas performance is you use performance, you want to improve performance in executive coaching. In health coaching, you want to improve self-care. So we like the definition that health coaching is helping people gain the knowledge, skills, tools and confidence to be active participants in their care so they can reach their self-identified goals. So based on that conversation 3 years ago, as I said, we put in for some money and £100,000 from the Regional Innovation Fund and set up a project training practice nurses in health coaching skills. And then with the underspend, we also trained GPs and ran 5 CCG programs. And then only last week, across the East of England LETB, we ran a procurement for 500,000 and hope to roll this training out across the East of England. So what do we do in NHS Suffolk? What we did was we wanted to improve the quality of life and health of people in East Suffolk through training practice nurses in health coaching skills. And we chose practice nurses because they are the linchpin of long-term condition management in primary care. They see the patients annually. We refer quite often to them for lifestyle advice. They do all the annual reviews, as I said. We gave them a 4-day accredited health coaching training, and Andrew's going to be describing what that consisted of. We included up to 16 practice nurses from 8 rural and urban practices, and then we followed the training up with longer appointments for an hour and then 2 45 minutes. In fact, the nurses said this was too long. They didn't need that length of time. And then each nurse practiced their skills on 20 patients with 3 sessions each. And they were observed in doing so. There was an issue around patient selection, and theoretically we would have liked to use a risk stratification model to identify those high-risk patients. But actually, in practice, not all the practices were using that model. So it was really, I know a patient, I'm going to refer them, etc. And also there was a debate about whether we actually do health coaching surgeries or whether we just include patients in our normal appointment system. We also were very lucky in that University College Suffolk were going to do an evaluation. And what they did was a pre and post coaching self-efficacy questionnaire based on the Stanford outcome questionnaire, patient survey, nurse interviews and data analysis. So from that small pilot, 199 patients experienced health coaching. We had 360 coaching appointments were completed and 68 personal health plans were completed. And the findings were that there was a statistically significant improvements in self-efficacy. And this tool that we used before and after coaching measures confidence in managing your own condition, your degree of managing the emotional impact of your condition, or judging whether you've got a change in your condition. So it was a really useful measure. But we also noticed that 98% were very satisfied with the care that they receive, and the majority would recommend it to other patients. Now, of course, in the study we did, we added 2 interventions, one which was health coaching and the other which was a longer appointment, and it's difficult in this pilot to separate the 2. However, Margaret, I think, really outlines the evidence around health coaching, so it was probably a little bit of both. And the evaluation came out. There is strong evidence that coaching techniques have been used effectively by nurses, and that these have contributed to an improved support for patients seeking to increase their levels of self-care. So as a result, I had a little bit of underspend, and we then ran a health coaching program for GPs, and I think we have a couple of participants here, and also 5 2-day CCG programs. Instead of us inviting participants to join the training, we said to organisations which organisations would like to participate, and you do the recruitment of the people who you think would benefit most. And they chose multidisciplinary teams, and that had a qualitative evaluation. So what clinicians say they're using the skills for are patients with long-term conditions, lifestyle and behaviour change, adherence and compliance with their medication, working with unexplained symptoms, pain management, recovery and rehabilitation, and mental health issues. And while I don't think we use it with significant mental health issues, certainly in my surgery, I use it quite a lot with mild anxiety and depression, where I contract with my patients to say, this is what I can do for you, this is what you can do for yourself, or what do you think you can do for yourself? The benefits that we've found from our programs, as I said, increase patient satisfaction and self-efficacy. But we've also noticed a mindset shift that the clinicians on the training can see a different way of interacting with patients and colleagues. What a relief. One colleague said to me, I wasn't sure whether this was going to work. I mean, I've only got 10 minutes, but I thought I'd try it on with one of my really difficult patients. She comes to see me every week. She normally takes about 25 minutes. And I think, oh my goodness, how am I ever going to, I'm going to be an hour late at the end of my surgery, and then people are going to be cross with me for running late. She said, I thought I would just stop and just have a go. So she said, so what I did, I just stopped and I just listened. And I asked her lots of questions, and she left in 9 minutes and said that was the best consultation she'd ever had. I think there's a lesson in listening. So I think they saw that the role shift was a relief from expert to enabler, and that helps us to have more personal resilience. But also, we felt that the people who attended the course, the training, were then more likely to go back into their own organisations and say, you go on it too, we need more training, more people want this, and act as champions for change. So the next step is to roll out this training across Midlands and East. We've done a few pilots. We need now to move on to having a broader base or early adopters who can then bridge from an innovation to make it more mainstream. And our next project, our next pilot, will include different levels of training, because there's a real push to roll this out at pace and scale. We've got to roll this out at pace and scale and get to as many people as possible. But there is a question around how much training is needed to create that mindset shift. So there are some clear questions that we haven't really answered. We're sort of on the way of answering them, but we haven't really got all the answers yet. And we hope that this next project will provide some of the answers. The first question is, can we please be clear on the terminology and objectives? I think Sue already mentioned this. There is so much confusion. What is health coaching? What is personalisation? What is shared decision making? You know, we really need to be clear on the terminology and what we're trying to achieve. Are quick interventions effective? And our experience would be that you can't change mindset from an e-learning package. You have to have some experiential learning in order to create that shift from expert to enabler. Who should be trained, and at what stage of career and to what level? We think that actually you need to be very competent with your clinical skills in order to then take on these additional skills and to combine them using a coaching approach in my 10 minutes, or maybe you might want to set up your own coaching surgeries. But you have to be competent at your clinical skills. Patient safety comes first. And then add on these skills. And I have to say, in general practice training, I think a lot of this stuff is done. It needs to be built on, but a lot of it is done already. And we tend to forget that early training. Which patients benefit most and how to identify them is a key issue. And if you have risk stratification tools, that's really, really helpful. But also ad hoc referral, and how can the skills be maintained? Finally, how do we align the training, as in Sue's house model, with activating patients and having systems in place that reinforce the skills I've learned? There's no point me going back into my practice going, I love health coaching, this is fantastic, I want to do it with all my patients, and not being supported by my partners, by the practice nurses as a whole. So, I just want to briefly, before I finish, just say, although I feel that we've taken the first few steps in Midlands and East and done quite a lot in this area, I'm very well aware of all the fantastic work that's been done elsewhere. So Rebecca's going to talk in a few minutes from the London Deanery of her experience. Steve Leitner and the National Shared Decision Making Programme has been doing a lot of work around coaching and decision aids, and Wendy Norton's going to speak in a few minutes. but also Tom Leach is here. He's done a lot of work around personal health planning and practices, and I know Bupa are also here and have done an enormous amount of work with a really big pilot in West Kent around health coaching that started to show really interesting results. So where do we want to get to? I've talked about my passion for health coaching, the limited experience that we've had in Midlands and East. I do think that health coaching and activating clinicians and activating patients are two sides of the same coin. You can't have one without the other. But I really believe and really support Alf in saying that I just don't think we're there yet in terms of training our workforce. It takes, 18 minutes before, as doctors, we start interrupting our patients. And I think that under pressure, all of us probably go back to a disease model. I think it's really, really, really important that just as we're saying that leaders need a flexible leadership style and that we shouldn't all be pace setters, for those of you who are in the leadership know-how in the room, we need a flexible consultation style. You know, we need to be able to adapt and be aware of adapting our consultation to the different stages that people are at in terms of their condition, in terms of their lives, in terms of their mental health. And we need to be doing that consciously. So I think that although we do need massive system change and we need to activate patients to have the house model fully embedded, I do think as clinical leaders, we also have a responsibility, not just within the consultation room, but in building the house in our own organisations. And here we are on the roof, building the roof, the systems that we need. So thank you very much.